let us quickly deal with the obstetrics today. Starting with the gametogenesis, there are a few important points which you need to remember, and that is about the main thing, that's spermatogenesis and the oogenesis, where exactly or which stage it gets arrested. Okay, so now from here, need to remember that the oogenesis starts right from the intrauterine life, but the spermatogenesis, it begins at the time of puberty. Okay, that is a major difference between this. And apart from that, we know that initially we have a primordial germ cell, may it be in the males as well as the females, and they derive from the epiblast. Okay, and after that, after deriving from the epiblast, they reach the yolk sac by 4th week, and then they migrate to the genital ridge by 5th week. So after that, all these processes going to occur. Okay, so remember, spermatogenesis, they begin at puberty, whereas oogenesis, they begin in the intrauterine life. Okay, so the total process till the meiosis 1 takes around 74 days in case of spermatogenesis. Okay, and later, after the meiosis 2, we have spermatids. Till that, we call it to be spermatogenesis, and afterwards, the spermatids which differentiate in different morphology, we call it to be a spermiogenesis, and thus we have a spermatozoa. Okay, but whereas the oogenesis, we have the oogonia first, then the primary oocyte. But here, what you need to remember is that till from oogonia to primary oocyte, we are going to have mitosis. But after that, okay, after that, the primary oocyte enters into the meiosis 1. But when it enters into meiosis 1, it gets arrested when it reaches the diplotin stage of the prophase. Okay, diplotin stage of the prophase, it gets arrested. Okay, after which the completion of the meiosis 1 happens at puberty. Okay, at puberty. See, at puberty, there is a menarche, right? So, where is then going to be a let search, and that is the time this entire meiosis 1 gets completed. And then we get a secondary oocyte. Okay, and but secondary oocyte also will get arrested, and that too in the metaphase 2. Okay, and this meiosis 2 is completed only if it gets fertilized. Okay, if the ovum gets fertilized, then only there is going to be completion of the meiosis 2. Otherwise, no. So these two things, which is very much important, remember. Okay, and that is meiosis 1 gets arrested in which stage? That is diplotin stage of the prophase 1. Okay, and the meiosis 2 gets arrested in the metaphase 2. Okay, metaphase 2. Now, over here, one more thing about the primordial germ cell, which you should remember is that, see, there is always a chance that a deviation can occur, okay, from normal primordial germ cells, and that is teratomas. Okay, so either it can be sacrococcygeal or the oropharyngeal teratoma that can happen. Now, next one is about the a little anatomy of it. See, talking about the ovum, okay, talking about ovum and secondary oocyte. See, we have a corona radiata, zona pellucida, and the perivitelline space. Okay, the space between the zona pellucida and the oolemma is known as perivitelline space. But what you need to remember is that this is the place where the first polar body is there. Okay, it contains the first polar body. Talking about the zona pellucida is the one which hardens after a sperm entry, okay, via the cortical reaction. Now, why? Because they need to prevent polyspermy. And next one, we have the corona radiata. Now, when the acrosomal enzymes are being released, okay, that is basically the hyalinase enzyme, they dissolve this corona radiata, and then the sperm enters. Okay. So, apart from that, the sperm, we have a acrosome. In the head, we have an acrosome that is derived from the Golgi apparatus. Then we have a middle space which contains the mitochondria in a spiral shape, and we have the tail. Okay, that is the axial filament containing dynein protein, which is helpful for the motility. Okay, just remember that. Next one is a little of the timeline which you need to remember. See, about the day it gets fertilized. Okay, if at all the eggs gets fertilized, and there is day 0. And where exactly it gets fertilized? It gets fertilized in the ampulla of the fallopian tube, which we had already discussed in the gynecology, correct? Next one, what happens at the day 3? Okay, day 3. Okay, so this is a one cell stage. Then we have a two cell stage. Then on day 3, what exactly happens? 1, 2, 4, 8, 6, 8, like that it goes off, right? So finally we are going to have a 16th cell stage, and that is what we call to be mulberry shape. Okay, mulberry shape, that is morula. But remember, it is still surrounded by the zona pellucida layer. Okay, it is going to be surrounded by the zona pellucida layer. This is the layer. After that, on the day 3rd, the particular morula, okay, it enters into the uterine cavity. Why? Because the tubes are there and the cilia and the tubes are there. So tubal peristalsis will occur, and thus the ovum will enter into the uterine cavity. Once it enters into the uterine cavity, the zona pellucida which is there, right, it will shed. Okay, now why it is going to shed, right? Because here a little fluid will enter into it and it is going to get swelled up, and automatically zona pellucida layer will stretch and will shed off. So finally we are going to have blastocyst. Okay, we are going to have a cluster of cells, that is blastocyst. And this particular blastocyst, we know what happens. It is going to differentiate into a trophoblast and an embryoblast. Fine. And this is the stage which goes into the implantation. So what exactly happens? First there is an apposition, then adhesion is through integrins, and then invasion by the metalloproteases. Okay, and finally by day 10 and 11 implantation gets completed. So if a question comes like, implantation begins on which day? That is day 6. It gets completed by day 10 to 11. In some textbooks it says day 12, but day 10 to 11 is the correct answer. Okay, so see, imagine that we have an endometrium, right, the residua basically. So there is going to be a implantation, but what exactly happens? We require a particular kind of layer, in fact a fibroid layer, which prevents the deeper penetration of the blastocyst. Okay, and that is what we call to be an Aiapget layer. Okay, if at all Aiapget layer is not there, then the implantation goes into the deeper layers, and then we get a placenta accreta spectrum. Okay, next one is about the blastocyst. I have already mentioned that blastocyst is differentiated into two structures, right? One is the outer, that is a trophoblast, which is again divided into a cytotrophoblast and syncytial trophoblast. And apart from that, we have an inner cell mass which is known as a embryoblast. This is the part which divides into a yolk sac and an amniotic cavity. See, yolk sac and amniotic cavity both are lined by, we know the trilaminar germ disc, if you remember, right? So we have an ectoderm, we have an endoderm, and in between we have this particular mesoderm. So ectoderm, okay, ectoderm is the amniotic cavity, endoderm is the yolk sac, and ultimately from the ectoderm, the middle part, okay, cells disintegrate and finally they proliferate, and then we are going to get a mesoderm. Correct? Okay, so that is about it. Now coming to the decidua as such, or the pregnant, or you can say the pregnant endometrium. That is what we call it to be decidua. This particular decidua is of 3 layers, or we call it to be decidua basalis. Then we have decidua capsularis, and then the decidua parietalis. Okay, so decidua basalis is the one which forms the maternal side of the future placenta. Maternal side of the future placenta. Okay, now what is decidua capsularis? That separates the blastocyst from the main uterine cavity. Okay, so for example, I'll show you. Okay, suppose here the black one, imagine this to be decidua. The one which is there, number 1 which I mentioned, this particular part is basically the decidua basalis, which is the maternal side of the future placenta. Okay, number 2 which I am showing is the decidua capsularis. Now, so this is the one which is going to separate the blastocyst from the other cavity. So that is known as a decidua capsularis. And number 3, the rest of the part, okay, is known as a decidua parietalis. Hope this is clear. Once again, decidua basalis is the one which is in the maternal side. Correct? Deciduous capsularis is the one which separates the blastocyst from the other part of the uterine cavity, and the one which lines the other part of the uterine cavity is known as a decidua paritalis. Okay, so this is it. So ultimately what happens is this particular, the embryo, whatever is there, okay, they are going to become larger and larger, right? And once it becomes larger and larger, this decidua capsularis and decidua paritalis are going to fuse or fuse together, and that is the time the uterine cavity obliterates, and that is around 14 to 16 weeks. Okay, next one, let us see the other few things. So, early pregnancy and the ultrasound features. So, over here, gestational sac. So, gestational sac on a transvaginal sonography. Okay, on a transvaginal sonography can be seen by 4th to 5th week. Okay, can be seen by 4th to 5th week. Remember this. Okay, so this is the first fetal structure which is seen. Okay, like an eccentric location, and see what happens is when there is a growth over here, there is going to be a growth only over here, right? Only on one particular part. So you can see that there is no symmetry over here. So that's what we call to be Pisacus sign. Apart from that, yolk sac can be seen by 5th week, and cardiac activity can be seen through a TVS, or can be noted through a TVS by 5th to 6th week. That is 21st day after the implantation, after the fertilization. That is the time when we can see a cardiac activity on a transvaginal sonography. Okay, so now how do we calculate a gestational sac or gestational age? So gestational age is basically a fetal age plus 2 weeks. Fetal age plus 2 weeks. Now over here, when we go for a TVS, there can be few signs which we can see. That is the intradecidual sign. This is the earliest sign. Whenever we can see a blastocyst deep in the endometrium, that is what we call to be an intradecidual sign. Remember, this is the earliest sign. Okay, after which we know that the decidua capsularis, paritalis and all are there, right? Okay, so that can be seen, and that is what we call it to be a double decidual sac sign. Okay, which confirms the intrauterine pregnancy. Then one more is there. When there is a differentiation between a amniotic cavity and a yolk sac, we call it to be a double bleb sign. Okay, double bleb sign. So simultaneously visualization of the amniotic cavity and the yolk sac is known as a double bleb sign. So these are the signs which you have to remember: intradecidual sign, double decidual sac sign, and double bleb sign. Okay, next one is about the fetal hemoglobin a bit. Okay, so less than 6 weeks, what happens is the yolk sac is going to produce, okay, there are a few, Portland, Goa 1 or Goa 2 hemoglobin. But then after 6 to 20 weeks, okay, 20 weeks, the the place is shifted from yolk sac. It has been shifted to liver and the spleen. They are going to produce a fetal hemoglobin. But after 20th week, remember, again from liver and spleen, it has been shifted to the bone marrow, and from there we do not have a hemoglobin that is going to transform into a adult hemoglobin. Okay, so remember, by before 6 weeks, who is taken up the job of producing the hemoglobin for fetus? That is a yolk sac. 6 to 20 weeks, there is a liver and the spleen, and after 20 weeks, there is a bone marrow. Okay, so let's see a few properties of fetal hemoglobin. We have alpha 2 and gamma 2 chains. They have a higher oxygen affinity than the adult one. Okay, and that is why the oxygen dissociation curve is shifted slightly left. Okay, and they have low 2-3 dpg. Okay, so now what are we going to do? We are going to do a APT test and a Kluwer-Betke test. So remember about this. This is very much important when we talk about the RH incompatibility and all that. Okay, so basically APT test means what? It basically can differentiate between a fetal blood, okay, and a maternal blood. They can actually differentiate. So because see, this particular fetal hemoglobin is structurally resistant to acids and alkalis. Okay, with that leaving that in the concept, APT test is being done. There is alkali one, wherein it differentiates between a fetal blood and the maternal blood. Then we have a Kluver Betke test. It is an acid which detects. It calculates the anti-D dose of the RH negative mothers. Okay, anti-D dose of anti-D dose and the RH negative mothers. I'll talk about that later. But apart from that, there are a few other things also which you have to remember. Apart from fetal hemoglobin, the ultrasound signs and all, here we have something called an amniotic fluid markers. Amniotic fluid marker quite important for the fetal lung maturity. Over here, remember the names. Okay, lecithin sphygmomyelin ratio. Okay, if it is more than 2, it indicates a matured lung. This is the most common test which has been done. Remember the test. I'm giving you pointers over here. Then we have the phosphatidylglycerol. Okay, the presence of this also tells that okay, we have a mature lung. This is the best and the most specific test, especially in the diabetic gestational diabetic mother. Then we have a lamellar body count. Okay, it actually represents the storage packets of the surfactant. More than 50,000, if it all is there, it says that okay, the lungs are matured. That makes, because matured lung can only produce surfactant, right? Then we have a shake or a bubble test. This is a qualitative test. What exactly happens is that the bubbles forming when mixed with alcohol indicates surfactant presence. Again, that when surfactant is there, again we say that okay, there is a matured lung. Correct? Okay, so that is about it. So not talking about the surfactant as such, we have spoken about surfactant, right? So the production of surfactant begins by 20th week. Okay, and by 28th week, the surfactant appears in the amniotic fluid. So when does the production starts? Production starts by 20th week, and it appears in the amniotic fluid by 28th week. Okay, 28th week. Next one, a little about teratogenic vulnerability. So we have divided the entire gestational period into 3 zones. One is a pre-embryonic period, next is an embryonic period, and we have a fetal period. Okay, so pre-embryonic period is the one which says that all or none law. See, all or none law means what? If any teratogenic things have been affected, either there will be complete loss of the pregnancy or the fetus will escape the injury. That is what we call it to be a all or none law. Either there is a fetal loss, or else there will not be any kind of structural birth abnormality. That is in the pre-embryonic, all or none law. Then comes the zone 2, wherein there is going to be a period of organogenesis. This is the time when there is any ill effects of teratogenic drugs or any exposure. The maximum risk occurs in this particular age, or this particular zone, the embryonic period zone. So exposure leads to profound structural birth defects. So, but when we talk about a fetal period, that is after 9 weeks, what happens is already the growth and neurological development that is going to occur at that point of time, right? Okay, organogenesis is already over. So growth and neurological development is going to occur in this particular period. So if at all there is going to be any ill effect or adverse effect, that is not for the structural defect. Okay, it is going to be a growth restriction or any kind of neurological impairment in the baby. Okay, so these are the 3 zones. Remember, pre-embryonic period, all or none law. That means either there is going to be a fetal loss, or there is not going to be anything. Okay, the fetus is completely going to escape any kind of injury. Then we have an embryonic period. In embryonic period, maximum structural deformity is going to occur, because that is a period when there is an organogenesis. The third one, that is a fetal period, that is after 9 weeks. What happens is, that is the time when growth and neurological development occurs. So growth restrictions or growth impairment will occur, as well as neurological impairment. No organogenesis, because it is already completed, right? So no new structural defects over here. Okay, so a little just remember as a pointers. See, if at all there is going to be an exposure of lithium, okay, lithium, remember the baby is going to get Epstein's abnormality. Okay, Epstein's abnormality, wherein there is going to be downward displacement of the tricuspid valve leaflets, and even atrialization of the right ventricle will be there. So lithium Epstein's anomaly. Okay, the paroxetine, SSRIs and all that, there is going to be cardiac septal defect. Okay, most common one is atrial septal defect. Okay, next one is a thalidomide. Okay, there is going to be phocomelia. There is extreme proximal limb reduction defect. Okay, the hands and the feet are attached near the trunk. Warfarin, they're going to have de-Silas syndrome. Okay, there is going to be chondrodysplasia punctata, that stippled epiphysis, and severely depressed nasal bridge will be there, and the maximum risk is by 6 to 9 weeks. So these are the few. Lithium, Epstein's anomaly, paroxetine, we have a cardiac septal defect, thalidomide, phocomelia, and warfarin de-Silas syndrome. Okay, now apart from that, imagine we have a torch infection, congenital ones, right? So what happens is that the most common congenital infection, always remember, that is going to be the cytomegalovirus. So cytomegalovirus is the one which is the most common congenital defect. But what is going to occur? There is going to be periventricular calcification, microcephaly, chorioretinitis. Okay, and there is going to be sensorineural hearing loss. The most common cause of sensorineural hearing loss is going to be the cytomegalovirus. Then next comes the Toxoplasma gondii. Intracerebral calcifications will be there. See, periventricular calcification, cytomegalovirus. Intracerebral calcifications, that is going to be Toxoplasma gondii. Okay, plus hydrocephalus and severe retinitis. This is more severe if it is transmitted in the first trimester. Next one is rubella, German measles. Okay, highest transmission risk is around less than 16 weeks. We have a classical triad: cataract or glaucoma, congenital heart disease, that is patent ductus arteriosus, and sensorineural hearing loss. Okay, post 16 week, if at all there is an infection, we are going to get neonatal purpura and radiolacent bone diseases. So which is going to have the highest transition risk? And that is going to be German measles or the rubella. And then most common congenital infection, that is going to be cytomegalovirus. So remember, periventricular calcification, cytomegalovirus, intracerebral calcifications, Toxoplasma gondii. The triad, please remember the triad, that is cataract or glaucoma, congenital heart disease, and sensorineural hearing loss in rubella. Okay, apart from that, parvovirus B19, highest risk is before 20th week. Okay, remember, this does not cause any kind of structural defect, remember. Okay, so there is going to be fetal anemia leading to high output heart failure and hydrops fetalis. This is something which is happening. Varicella zoster virus, greatest risk is between 13 to 20 weeks. There is going to be cicatricial skin lesions, that is zigzag scarring, severe limb contractures and deformities, and cortical brain atrophy. Then we have Zika virus, that is what we call to be a flavivirus. Okay, here we are going to have severe microcephaly. Okay, prominent occiput and macular scarring, plus fetal clubfoot is going to be there in Zika virus. Okay, so severe microcephaly, clubfoot in Zika virus, cicatricial skin lesions in varicella zoster, and anemia leading to heart failure leading to hydrops fetalis in parvovirus B19. Okay, next one, let us go into the other topics. Next one is about the pre-labor rupture of membranes. So talking about pre-labor rupture of membrane, okay, there is a classical baseline which you remember. So we have something called premature pre-labor rupture of membrane. Okay, that is before 37 week, but the pre-labor rupture of membrane is by after or at the time of 37th week. Okay, so remember that. Now what we are going to do over here, we are going to examine the urine and the amniotic fluid. Okay, see what exactly happens when there is a rupture. There is going to be fluid leak, right? So now we are supposed to understand whether that is the urine which has come out or the amniotic fluid, correct? So now, if at all there is a typical odor and it stops after the fluid which is coming out, it stops after the bladder is empty, that means definitely that is going to be the urine. But on the contrary to it, if at all we have a odorless and continuous leak, then it can be an amniotic fluid. But to confirm it, we are going to do two tests. One is a nitrazine paper test, and the other one is a fern test. Okay, so if at all there is a delicate ferning pattern, that is definitely amniotic one. And nitrogen paper test, if it turns blue, okay, that is because of the alkaline one. Okay, we say again that it is an amniotic one, amniotic fluid. Okay, there are other modern definitive lab assays, that is actin test and amnesia, but usually in the question papers they usually ask about the nitrogen paper test and the fern test. Okay, but apart from that, if at all we are going to do an examination, look for pooling in the vaginal vault, observe fluid leaking, whether it's from the os itself, and even a Valsalva, the cuff maneuver can be done to induce a leak. But digital vaginal examination should be always prevented, should not be done actually, to prevent chorioamnionitis. So that is, now how are we going to manage it? First of all, we have to admit and monitor them, give corticosteroids, tocolytics and all they give. Okay, but apart from that, we are supposed to add magnesium sulfate if the lady is below 32 weeks. Okay, below 32 weeks. Now, there is one more thing. What you need to remember is that after 37th week, immediate induction of labor is supposed to be done. Okay, after 37 weeks, immediate induction of the labor, vaginal delivery is probably done. But before 32 to 34 weeks, remember, magnesium sulfate is the protocol. Between 34 to 36 weeks or plus 6 days, nothing, just admit and monitor. But usually they give a corticosteroids. Next is about the chorioamnionitis. See, chorioamnionitis, there are few presumptive criteria and a definitive criteria. So talking about the clinical ones, clinical one, fever should be more than or equal to 39 degrees Celsius, or it should be more than 38 degrees Celsius, but we have to check it 30 minutes apart. Plus, either they should be fetal tachycardia, or a maternal WBC should be more than 15,000, or there should be a purulent discharge from the os. So fever is a definitive one, plus either there should be fetal tachycardia, or the increased WBCs in the mother, or a purulent discharge from the os. Any one should be there. Okay, but apart from that, uterine tenderness can also be there in the case of chorioamnionitis, but then that is not diagnostically important for us. But then we have something called a definitive criteria, where we send the patient for a lab investigation, amniocentesis. Over there, we find out some kind of gram stain positive is there. Okay, culture is also positive. Then decreased glucose in amniotic fluid. Then increased WBC in amniotic fluid. Also, there is histopathological signs of inflammation. These are the definitive criteria for telling that we have a chorioamnionitis. Okay, so clinical we know fever plus fetal tachycardia bar maternal WBC more than 15,000 bar purulent discharge from the os. But definitive criteria, we have gram stain positive, culture positive, decreased amniotic decreased glucose in the amniotic fluid, increased WBC in the amniotic fluid, or lastly we have the histopathological signs of inflammation. But what are we going to do? We are going to induce the labor, vaginal one, immediately. That is something which we have to do for this case. Okay. Next one, let us talk about abortions. See, abortions can be of spontaneous abortion or induced abortion. Correct? See, spontaneous is it can be isolated, or it can be a recurrent pregnancy loss. See, usually it can happen in the first trimester and second trimester. So let us see the causes now only. See, talking about the isolated one, remember that the most common cause is the chromosomal anomalies. Most common is chromosomal anomaly, in which trisomy 16 is most lethal and trisomy 21 is the most viable one. Okay, so first trimester abortions, spontaneous one, it is usually because of the most common causes, chromosomal anomalies. Okay, then we have recurrent pregnancy loss, that is more than or equal to 3 losses, which is less than 20 weeks. And induced one, we know that is MTP, right? Now talking about the idiopathic, okay, recurrent pregnancy loss, what are the causes can occur? Either it can be because of endocrinopathies, either hypothyroidism or uncontrolled diabetes mellitus, PCOS, luteal phase defect. When we talk about uterine anomalies, it can be cervical incompetence. Usually that happens in the second trimester. Then we have the septate uterus. Okay. Septate uterus usually causes early recurrent pregnancy loss. Then immunological one, that is the Apla syndrome. This is the single most common defined cause, Apla syndrome. Okay. Then we have chromosomal, which is a balanced translocation of the chromosomes. That can be the reasons for a recurrent pregnancy loss. But let's talk about the cervical incompetence and the cerclage management. So talking about the cervical incompetence, okay, basically what happens is the cervix cannot hold up together. Okay, so they dilate, and that is what we call to be incompetence of the cervix. So what are the diagnostic criteria? See, the history says that more than 2 painless abortions, that too in the second trimester, has occurred. Okay, so USG, when it is done at 18 to 24th week, we can see that the cervical length is less than 2.5 centimeter, wherein it should be more. Then it say that internal os diameter is more than 2 centimeter. Internal os diameter is more than 2 centimeter. Cervical length is less than 2.5 centimeter. Okay, and we have a progression of shape from T shape cervix to Y shape cervix to V shape cervix and to U shape cervix. You can see the dilatation, progression of dilatation. Okay, so how are we going to manage this particular case? That is through a surgical management, that is McDonald cerclage. Okay, this is the most common one. Okay, suture it off. The purse string suture with non-absorbable material and the cervico-vaginal junction has to be done. Apart from that, we have Shirodkar cerclage also, in which cervico-vaginal junction is cut and suture is applied exactly at the internal os. Okay, so this is having the less failure rate. Okay, so remember, not only that, along with this, we are supposed to give a progesterone, like a Susten and all that. We are supposed to give them up to 36th week plus 6 days, because after 37th week we can do a premature pre-labor rupture of the membrane and then induce the labor and then deliver the baby. Okay, so we have an MTP Act, just a comparison between the 1971 and the 22, the recent one. See, up to 20 week it was said in the 1971, but right now we have an upper limit, that is 24 weeks. Yeah, 24 weeks in special cases like minors, rape survivors and mentally ill people. Contraceptive failure up to 20 week in both, still the same. Fetal anomaly 20 weeks, but right now we do not have an upper limit. Okay, and this is a decision which is strictly taken by the state medical board. Then coming to the opinion required, single doctor up to 12 weeks, but now we have a 20th week option. Opinion of 2 doctors required by 12 to 20 weeks in 1971. Now it is 20 to 24 weeks. Okay, but still consent is only for the female is required. If the patient is less than 18 years old or mentally ill, guardian consent is mandatory. Okay. Next one, a little about ectopic pregnancy. See, we know that pregnancy takes place where, fertilization takes place where, that is in the ampular region. Correct. So now when we talk about ectopic pregnancy, supposed to be the uterus, that's what you can say, the implantation is not occurring at the fundus, right? So now where exactly you can see the most common site for the ectopic pregnancy is again the ampulla, most common overall. Okay, and so here exactly this is the point where tubal abortions occur. Okay, tubal abortions occur by 6th week. Right after 6th week, there is going to be rupture of the tube. It can occur. So narrowest anatomical sphincter, that is the interstitium, okay, or the cornua. Okay, so basically what happens is the tube, if at all it is being longer, okay, probably it is going to be long. So what happens, the cilia, even though it is trying to push the fertilized zygote, okay, the morula and all that inside the uterine cavity, it still does not reach. So there can be a chance that the the implantation takes place inside the fallopian tube itself. So fallopian tube is the most common part where an ectopic pregnancy takes place. Okay, so apart from that, remember, ectopic pregnancy in the tube is the most dangerous type. Okay, most dangerous type. There can be other types also, we call it to be angular pregnancy, that is round ligament, okay, round ligament, and cornual ectopic pregnancy where the round ligament is medial, okay. So you can see round ligament over here. This is an angular pregnancy over here, right? Angular pregnancy is over here. So the retrograde, they try to go outside of the fimbriae. The other one is cornual ectopic pregnancy in the cornua. Okay, now there is always a previous history of ectopic pregnancy. That's the highest risk. If one was there, next time it can be. And the most common risk is a PID or the salpingitis. So what exactly happens is that if at all there is a chlamydia infection produces PROKR2. Okay, there's a protein, and this can lead to an early tubal implantation. Okay, other risk factors are tubal surgery, endometriosis, smoking, because smoking is the one which impairs the tubal mobility or motility. Apart from that, progesterone only contraceptives. Okay, progesterone only contraceptive pills, that also can lead to a ectopic pregnancy. Apart from that, what exactly we are going to do? We are going to find out the signs and symptoms. So symptoms wise, there is a triad for ectopic pregnancy. Abdominal pain most consistent, amenorrhea will be there, and vaginal spotting. These are the three important symptoms or triad which we are going to get. But apart from that, go in for a transvaginal sonography, and we are going to see an extrauterine gestational sac with a yolk sac or an embryo in the fallopian tube or wherever it is. So plus we have one more thing, we can get an empty uterus, complex adnexal marks, as well as ring of fire appearance. Okay, so this is one we are going to get. Imagine if uterus is empty, what are we going to do? Check for HCG level. Okay, if at all HCG level is still more than 2000 international unit, diagnose that it can be ectopic pregnancy. But if it is less than, then again after 48 hours again go and do a HCG. So if at all it increases again or it doubles, we can say that okay, it can be an intrauterine pregnancy. It decreases, that means an intrauterine abortion. Okay, slow rise is there, then it can be an ectopic pregnancy. But a definitive investigation, if at all they are asking for ectopic pregnancy, your answer should be transvaginal sonography, okay, and not an HCG. HCG is not a definitive investigatory finding. Okay, TVS is a definitive investigation which we have to send for an ectopic pregnancy. Okay. Next one is about the gestational trophoblastic disease, wherein we call it to be the first one we are talking about is the hydatidiform mole or molar pregnancy or a vesicular mole. Coming over here, we have two types, that is a complete mole and a partial mole. Okay, so complete mole, remember that entire chromosomal pattern is paternal. Okay, maternal one, mother's side is inactivated. Okay, but when we talk about partial mole, okay, here one extra chromatin will be there. Mother's is also there, father's is also there, but extra one chromatin will be there which is of a paternal origin. Okay, so here two sperms fertilize one ovum, that is partial mole. Two sperms are going to fertilize one ovum. Okay, partial mole. But here what exactly happens? Ovum is there, but the chromosomes over here is not working of the mother. So we have dispermine. Okay. So what is going to occur? One of entire will be of the father. Okay. So here in case of complete mole, will there be a fetal tissue? No, there will not be a fetal tissue. Plus there is going to be snowstorm appearance in USG, and HCG is going to be markedly elevated, and because of that there can be hypothyroidism or a hyperemesis gravidarum. Okay, but whereas in partial mole, fetal tissue may be present. Okay, may be present. Fine. Next one, a little about the basic things, that is GTPAL. See, first initially we used to say as GPALD, right? Okay, gravida, para, abortion, living and death. But afterwards, we have something called G, P, A, B, C, and D. Okay, so G means gravida, we know total number of pregnancies regardless of the outcome. Then we have a para. Under that, you see, we have the A stands for T, that is term delivery. B, okay, the term delivery means what? Between 37 and 41 days plus 6 days. Then we have B stands for preterm, between 20 to 36 weeks plus 6 days. Then C for abortion, okay, which is less than 20 weeks. Then we have living, okay, D for living, number of living children at present. Okay, so please remember GTPAL, that is the recent scoring system which has been done. Next one, let us see about the diagnosis of pregnancy. The early clinical signs, we have Goodell sign, that is softening of the cervix, and that is by 6th week. Then we have by 8th week, we have something called a Chadwick sign, as well as we have an Osiander sign also, in which, see, Chadwick sign is something where Chadwick or Jacquemus sign, you can call it to be a bluish discoloration of the cervix or vagina. But wherein Osiander sign is pulsations which you can feel in the lateral vaginal fornix. Pulsations in the lateral vaginal fornix is known as a Osiander sign. Chadwick sign is bluish discoloration, and Goodell sign is softening of the cervix. Okay. Now, apart from that, absolute diagnostic signs, fetal heart sounds can be heard by stethoscope itself by 18 to 20th week. Fetal movements can be palpated by the examiner. Fetal parts distinctly palpable. USG evidence will be present, as we had already seen, right? Plus X-ray visibility of fetal skull after 16th week. That is an absolute contraindication. But if at all we are doing it after 16th week, we can see your fetal skeleton. Next one, talking about the fetal antenatal visits. See, this is the universal first visit protocol. Okay, as soon as the lady comes and says that she's pregnant, and then we send them for a few tests, blood and RH typing, basically, to see whether the mother is RH negative, or even the father is having an RH positive, because that says it's a high risk, right? Then infections like HIV, syphilis, then we send them for a HBsAg and all that. Next one, a complete blood count is being done 4 times during the pregnancy. Okay, just to see here about the hemoglobin. Okay, to rule out any kind of anemia which is present in the lady. Apart from that, gestational diabetes, for that we are going to do it first. In the first visit, one time we are going to do, that is pre-gestational one. Then 20 to 28th week again we are going to do. Okay, where that is the time when the insulin resistance is maximum in pregnancy. Then check for rubella, that is test for IgG. But even though we are checking, vaccinations cannot be done because they are contraindicated. Okay, but torch, imagine we shouldn't do torch screening, okay, in pregnancy. Next one is about the first trimester screening. So talking about the first trimester screening, dual test or biomarkers, Down syndrome and Edwards syndrome are the one which you're going to find out. Okay, so in case of Down syndrome, remember HCG will be more, but the plasma specific protein A will be pregnancy specific plasma protein A. Okay, that is going to be decreased. Whereas in Edwards, both HCG and pregnancy associated plasma protein A will be decreased. So over here, HCG is more in case of Down syndrome. Okay, whereas in Edwards, both are reduced. At the same time, in the first trimester, we are also going to do a nuchal translucency test. Okay, wherein again the nuchal translucency, if at all, it is going to be less than 3 millimeter. That states that there can be some kind of chromosomal or cardiac defect. Okay. Apart from that, check for neutral head position or inner border to inner border. That is the place we are going to measure all this nuchal translucency. Even the mid sagittal plane, all those areas we are going to check. Okay, and then we are going to find out whether it is more than 3 millimeter or less than 3 millimeter. The same way, the second trimester also we are going to do nuchal skin fold thickness, and if it is more than 6 millimeter, again that is a problem. Okay, wherein apart from that we find out that there is going to be absent nasal bone, chorioid plexus cyst is present, and echogenic bowel or cardiac focus. But apart from that, in the second trimester, we have something called a quad test. Okay, markers for Down syndrome. Already we know that in Down syndrome, HCG will be more, right? But add on to it, we have inhibin A is also more in case of Down syndrome. Rest of the thing, there is alpha fetoprotein, and the unconjugated estriol will be less in case of a Down syndrome. Okay, so in Down syndrome, what and all will be there? Increased beta HCG, decreased pregnancy associated plasma protein A, decreased alpha fetoprotein, decreased unconjugated estriol, but increased inhibin A will be there. Okay, so next one, let us come to invasive techniques, that is chorionic villi sampling and amniocentesis. See, chorionic villi sampling can be done by 11th to 13th week. Okay, never, it should not be done below 10th week, because there can be limb defects and all that. So what are we going to take the part? We're going to take a trophoblast or a chorionic frontosum. Okay, and then we are going to check. Okay, risk of placental mosaicism will be there over here, but still, okay, by 11th to 13th week, that is the time when we are going to check. We have amniocentesis by 16th to 18th week, we are going to check. And what is the study material? That is nothing but the fibroblast or the amniocytes. Okay, this is usually the safest procedure, but the results take a longer time. Okay, next one, apart from that, we have something called a non-stress test as well as biophysical score. Okay, so in case of a non-stress test, we are going to check for the fetal heart rate accelerations in response to the movement. Okay, so there should be more than 2 accelerations in 20 minutes. This is very much important. Okay, so acceleration means what? 15 beats per minute lasting for 15 seconds. That is what we call it, an acceleration. So more than 2 accelerations in 20 minutes, that is what is a non-stress test. That is what we are going to supposed to measure. That is normal. Okay, that is a healthy criteria. When we have a few other things, that is a biophysical score, that includes a lot many things. First of all, we have a non-stress test. Okay, reactive one. Then fetal breathing movements, if at all it is more than 1 episode in 30 seconds. Okay, then we have gross body movement, that is more than 3 movements. Then fetal tone, if it is 1 episode, extension and flexion, if at all it is present, and amniotic fluid, that is single largest vertical pocket, it is more than 2 centimeter, we say that okay, there can be a fetal hypoxia. Okay, fetal hypoxia. So usually they do it for 30 minutes via USG, just to check all these. Next one, a little about maternal adaptations and hematological shifts. So talking about this, let us see about what happens in the volume of our blood and all that. So talking about the plasma volume, okay, and the RBC volume, you see that plasma volume is going to be increased, even if we talk about the RBC volume, even that is also going to be increased. But whereas the hemoglobin concentration, there it's going to be decreased over here, because there is a physiological hemodilution which is taking place. There is going to be increase in the total leukocyte count. Okay, pregnancy it goes around 15,000 or more, but the blood viscosity is going to be decreased. So plasma volume, RBC volume, and the WBC count is going to be increased, whereas the hemoglobin concentration, the blood viscosity is decreased during the time of pregnancy. Okay. What about the coagulation state? Now we know that pregnancy is a hypercoagulable state, right? So that means all the factors, especially clotting factors, especially fibrinogen and factor 1 are increased. But when we talk about a fibrinolytic activity, that is decreased, and anticoagulants, majorly the protein C and the protein S, is decreased in case of a pregnancy. Coming to the respiratory system, the inspiratory reserve volume is unchanged. Tidal volume, it is increased. The expiratory reserve volume and the residual volume are decreased over here. So the inspiratory capacity is increased, where the functional residual capacity is decreased in case of a pregnancy. Okay, so telling about that, remember What and all are going to increase? Tidal volume, minute ventilation, inspiratory capacity, oxygen consumption. All these are going to be increased in case of our pregnancy. But residual volume, expiratory residual volume, sorry for the spelling mistake, functional residual capacity, expiratory reserve volume, and the blood carbon dioxide levels. All these are going to be decreased in case of our pregnancy. They were unchanged, vital capacity is unchanged, and the respiratory rate is unchanged. So progesterone, they usually just remember that progesterone drives hyperventilation, okay, which is going to lead to respiratory alkalosis, and it is compensated by kidneys by excreting the bicarbonate, and that is why there is going to be a state of compensatory metabolic acidosis in case of pregnancies. When we talk about GI, there is going to be decreased lower esophageal sphincter tone. Why? Because progesterone is there in our system, right, and it relaxes the sphincters. Gallbladder motility is also going to be decreased, and GI motility is also going to be decreased, all because of the progesterone effect. Apart from that, by fifth or sixth week, the ladies get morning sickness usually. Okay, not everyone, not a definitive one, but they can get, and it subsides by 16th week. Okay, but the vital signs, everything are normal. If at all it is not normal, then we talk about a hyperemesis gravidarum, in which there is going to be weight loss, which is more than 5% of the pre-pregnancy weight. Ketonuria is going to be there. Metabolic alkalosis and hypokalemia will be there due to excessive vomiting, and raised hematocrit value, okay, due to hemo concentration. These are going to be there in case of a hyperemesis gravidarum. Okay, apart from that, let's talk about the renal physiology, wherein the kidney increases by 1 centimeter. Urinary stasis is also going to be there, again because of progesterone. Then bilateral hydroureter is going to be there, okay, because there's going to be dextrotation of the uterus. Because of that, a bilateral hydroureter will be there. Okay, apart from that, we know that blood flow is going to be increased, right? So renal blood flow is increased, thus the GFR is increased, therefore increased excretion of the urea, uric acid, and creatinine will be there, and because of that, the serum urea is going to be decreased, serum uric acid is going to be decreased, and serum creatinine is also will be decreased in case of a pregnant state. Okay, next is endocrine and metabolic, wherein when we talk about carbohydrate metabolism, see, pregnancy induces peripheral insulin resistance, okay, because we require the glucose for the baby, the fetus, right? So primary, what is going to be there? The fetus requires the glucose, and because of that, the mother is going to have a peripheral insulin resistance. It will be more in the body, and the primary hormone which is responsible for this is the human placental lactogen. Okay, human placental lactogen, and which is the time when it is peak, that is 24 to 28th week. Okay, 24-28th week, and because of that, we are going to have a fasting hypoglycemia and a postprandial hyperglycemia. Endocrine, when we see, anti-pituitary size is going to be increased, all adrenal hormones except the DHEAS, okay, that is going to be increased. Basal metabolic rate is also going to be increased by 10 to 20%, and prolactin is increased, but it is at its peak at the time of labor. Okay. So next is about the trimester wise and the age calculation. So the best parameter in the first trimester is basically the crown rump length, okay, which has been measured from the outer margin of the cephalic pole to the rump. Then coming to the second trimester, wherein the best parameter is the biparietal diameter. Okay, so third one, which is most important, the best single parameter is the femur length. Now, if at all the femur length is short, it is basically a marker for skeletal dysplasia or trisomy 21. Okay, so best overall estimation is basically a combination of the head circumference, abdominal circumference, then the femur length, and the biparietal diameter together. Okay, so how are we going to calculate it? See, when we calculate the gestational age in the first trimester, it is basically the crown rump length plus 42. Okay, So please remember that. Next one is about the fetal hypoxia. So remember that, whenever there is a hypoxia when it begins, so what exactly happens? There is going to be a decreased fetal movement, which is the early marker. So what is the early marker for fetal hypoxia? That is the decreased fetal movement. Okay, that itself means that there is going to be decreased fetal heart rate reactivity, right? So automatically what is going to occur? There is going to be circulatory redistribution. Basically, whenever something happens, they flow the blood towards the brain sparing effect, what we call it to be the decreased resistance in the middle cerebral artery. Okay, that is being done so that we prioritize brain blood flow and decrease the damage in the brain. But now over here, at that point in time, what is going to happen? Placental insufficiency is going to occur, right? So whenever there is a placental insufficiency, there is going to be impedance in the fetal placental circulation, and that is why there is going to be increased resistance in the umbilical artery Doppler. Okay, and that is why later on there is going to be progressive decompensation method, in which absent end diastolic flow will be there and reversed end diastolic flow will be there, like an agonal pattern and all that. Okay, so uh, this is what about the fetal hypoxia. It's a progression flow. But then what you need to remember is that how are we going to understand it? Check for the fetal uterine artery Doppler. Do it. Okay, which is going to give you maternal prediction. And then also check for the middle cerebral artery Doppler for fetal prediction. Okay, so when we talk about uterine artery Doppler, they are going to tell you whether there can be a chance of preeclampsia. Okay, it can predict a preeclampsia. Okay. And if at all there is a diastolic notch beyond 22 to 24 weeks, that is a marker, diagnostic marker for preeclampsia. But when we go in for a fetal prediction, that is through middle cerebral artery Doppler, it focuses on assessing whether there is a fetal anemia. Okay, diagnostic marker, we go in for a peak systolic velocity. If it is more than 1.5, which indicates a severe fetal anemia. Okay, next one is about the cardiovascular changes and risk in pregnancy. So we know that normal pregnancy changes, what happens? There's going to be left axis deviation, right, up to 15 degree, and apex bit is shifted to the fourth intercostal space. Okay, because diaphragm is pushed upwards, right? And even the heart sound 3, S3 is heard. An injection systolic murmur is also there. But whenever we talk about diastolic murmur, remember we need immediate evaluation, because that can denote a heart disease in 80% of the cases. And severe symptomatic aortic stenosis or aortic dilatation, which is more than 4 centimeter, can give you an idea of Marfan's syndrome. So most common heart condition is what? Mitral stenosis, which is rheumatic one. Most common congenital disease, if we talk about, that is atrial defect. Okay, but which is the one which is having the highest maternal mortality? That is Eisenmenger syndrome. So remember that. Plus something about anemia. See, basically, before that, let us talk about the iron deficit. See, total iron which is required in pregnancy is 1000 milligram. Okay, in which 500 goes for maternal RBC, 300 for fetus via the active transport, and 250 nearly, that is lost via urine, sweat, and urine, stool, and sweat. Okay, so just remember. Now what exactly happens is that there can be two types. Okay, either it can be a microcytic or a macrocytic. Now what you need to remember is that if at all it is less than 75 femtoliter, it is microcytic. More than 100 femtoliter, that is what call it to be a macrocytic. Okay, in which we are supposed to find out the Menso's index, that is MCV bar RBC count. Over here, if it is less than 13, it is thalassemia. If it is more than 13, it is iron deficiency anemia. So what are we going to do? We are going to do a gold standard indicator. Check for serum ferritin. Okay, check for serum ferritin. We are going to get it whether we have an iron deficiency anemia or not. Because if at all the serum ferritin is less than 20 microgram per deciliter, that means okay, it is a iron deficiency anemia. And what is the true gold standard investigation? That is a bone marrow biopsy. okay, because there is going to be absence of stainable iron over here. So next one, a little about hormones. See, we know that placenta secretes a lot of things, right? Progesterone secretes estrogen, it secretes HPL, HCG, pregnancy specific plasma protein, then it secretes relaxin, like many more. But what you need to remember is that there are few important things, okay? Like for example, HCG. Okay, talking about HCG, what is the function of HCG? HCG maintains the corpus luteum of pregnancy. Number one, whenever there is a male fetus, it stimulates the Leydig cells so that it secretes testosterone, thus developing the external genitalia of the male. It helps in steroidogenesis. It helps for you know um, thyroid hormone functions and all that. But apart from that, we need to know a little about HPL, that is human placental lactogen. Otherwise, we can call it to be human chorionic somatomammotrophine. Correct. So it's a main hormone responsible for progressive insulin resistance. Correct. So it is aided by progesterone, CRH, and cortisol. Okay. Now, apart from that, uh, this insulin resistance when we talk about, it peaks between 24 to 28 weeks. Okay, that's a particular screening window for that. And we know that when we talk about insulin resistance, the fetus is going to depend upon the mother entirely for the glucose, right? And but the thing which you need to remember is that how is the glucose getting transferred from the mother to the fetus, right? It is through facilitated diffusion. Okay, facilitated diffusion via the GLUT1 and GLUT3 receptors. Okay, GLUT1 and GLUT3 receptors. Okay, this is important. Next one is about the gestational diabetes. So we have something called a pre-gestational diabetes and a gestational diabetes. See, pre-gestational diabetes can also be known as an overt diabetes. Okay, now over here, pre-gestational diabetes means what? It has been present before the conception in the first trimester. So the lady who is pregnant is hyperglycemic from day one. That is what we call to be a pre-gestational diabetes or an overt diabetes. But when we talk about gestational diabetes mellitus, it means it develops during pregnancy. Okay, typically diagnosed in the late second and third trimester. Next one, free radical formation will be there from day one. That is during organogenesis, right? That is the time when the organogenesis and all is going to occur, and there can be more structural defects will be there when a lady is having a pre-gestational diabetes, not in a gestational diabetes. Okay, because after organogenesis is complete, then only we are going to get a gestational diabetes as such. So moderate risk is there in gestational diabetes, but highest risk is in the pre-gestational diabetes, otherwise which we call it to be a overt diabetes. Okay, so most common anomaly is going to be what? The ventricular septal defect. Okay, and most specific anomaly is the sacral agenesis over here. So among these two, that is overt diabetes and gestational diabetes, which is the one which is going to have congenital malformation? Your answer is overt diabetes or a gestational diabetes. Okay, the one which is not having congenital malformations, and that is gestational diabetes. Okay, no, next one, let us see the diagnostic cutoff. So in case of an overt diabetes, the fasting blood glucose or fasting blood sugar will be more than 126. 2-hour ppbs, so the rbs is going to be more than 200, and hbA1c is more than 6.5. Okay, next one, talking about the fetal risk, I've already mentioned, that is pre-diabetes is going to have. And whether there will be any genetic defect, there is no risk of genetic defect in either of them. Okay, let us talk about the challenge test, that is diagnostic cutoff for the gestational diabetes. We have something called a glucose challenge test. Correct. So glucose challenge test, we are going to give 50 gram of glucose. No fasting, check at 1 hour. So if at all it is less than 140, no, not a problem, it's normal. 140 to 199, we can suspect that there can be a GDM. Okay, or if it is more than 200, definitely it is confirmed that it is gestational diabetes. So the people who are going to have 140 to 199, we go for a glucose tolerance test, in which 100 gram of glucose has been given, and 8 hours fasting is also required. In that, fasting 95, no problem, cutoff. Okay, 1 hour 180 is the cutoff. 2 hours 155 is the cutoff, and the 3 hours it's going to be 140 cutoff. Okay, if at all either two of them are abnormal value, we say that the lady is having gestational diabetes. Simple. Okay, but apart from that, we have something called DIPSI guidelines also. Okay, in which that's the first antenatal visit, in which we are going to give 75 gram of glucose. Fasting is not required. Check after 2 hours. Less than 140, normal, that is negative, but we have to repeat it after 24 to 28th week. Then 140 to 199, gestational diabetes mellitus is there. Okay, more than 200, definitely the lady was already having a diabetes, so she comes under pre-gestational diabetes or over diabetes. Okay, next one, talk about the fetal macrosomia. See, we know we are talking about hyperglycemia, maternal hyperglycemia, right? They are going to cross the the placental barrier, and there is going to be fetal pancreatic stimulation. So at that point of time, the baby is also going to have hyperinsulinemia, correct? Because fetus is also going to make its own insulin, right? So automatically increased insulin like growth factor is going to be there, and finally there is going to be fetal macrosomia, in which the fetal weight will be more than 4 kilogram or so. Okay, but imagine there is going to be fetal hyperinsulinemia or macrosomia. Okay, so fetal hyperinsulinemia, they are going to inhibit the lipolysis. So means what? Inhibiting lipolysis, that means fat deposition is going to be there, right, on the shoulders and abdomen. And so these are the people who go in for shoulder dystocia. Okay, but one more thing which the hyperinsulinemia does is it decreases the fetal surfactant production. That means what? Lung maturity is delayed. It means what? The baby can get into respiratory distress syndrome. So these are the things which are going to occur in case a baby is having a macrosomia or hyperinsulinemia. Okay, so what are the common anomaly which which the baby can have if the mother was already diabetic, that is over diabetes? So number one is CNS defects. Okay, neural tube defects will be there. Okay, this is the second most common. Okay, but apart from that, most common is what? Ventricular septal defect, which I have already mentioned. Most specific one is what? Transposition of the great arteries. Okay, plus there can be a hypertrophic cardiomyopathy. But apart from that, sacral agenesis and caudal regression syndrome will be there in the baby. Okay, so remember, the sacral agenesis is the one which is most specific anomaly for overall the diabetic mothers. Okay, and it is also highly associated with single umbilical artery. Okay, single umbilical artery. So please remember that. Next is shoulder dystocia. So delay of more than 1 minute after the head delivery. Okay, that is what shoulder dystocia. There is going to be stretching of the shoulders and the neck, right? So what is the one which you're going to get? Brachial plexus injury. Okay, Erb's palsy, there is going to be there. Now apart from that, imagine the head comes out but the shoulder is stuck. So automatically what is going to happen is head is going to recede back. That is what we call it to be a turtle sign. Okay, turtle sign. Next one, how are we going to deliver the baby? We are going to deliver the baby, just remember the name, and that is Mack-Roberts maneuver. Okay, Mack-Roberts maneuver. Okay, basically we are going to increase the space for the shoulders also to come out. So over here I have already mentioned brachial plexus injury will be there. So there is going to be Erb's palsy. Okay, C5 to C6. And what happens to the mother? There can be always a chance of postpartum hemorrhage. Right? So now let's go into hypertension. So talking about hypertension, the pregnant patient, okay, with a BP of more than 140/90. If it is more than 20 weeks of gestation, it can be chronic hypertension. Okay, even after 12 weeks, it does not come back. Okay, sorry, less than 20 weeks, it is chronic hypertension. More than 20 weeks, it is pregnancy-induced hypertension. Okay, so if at all there is a proteinuria along with pregnancy-induced or any kind of end organ damage, we call it to be preeclampsia. And if at all no proteinuria, no end damage, it is called gestational hypertension. Okay. So let us see what exactly happens. What's the pathophysiology? Just one word you need to remember is that in case of normal pregnancy, okay, there is going to be extravillous cytoblast, cytotrophoblast, which will be there. They are replaced. Okay, they replace the lining of the metal spiral artery, so that the diameter of the arteries become larger, and there is no resistance. But over here in preeclampsia, what happens is incomplete cytotrophoblastic invasion will be there. Okay, so it means what? Spiral artery remains narrow, and there's going to be high resistance. So decreased volume will be there of the blood. That means what? Decreased hypoperfusion and ischemia will be there. Okay, and ischemic placenta will release increased vasoconstrictors, and they are going to release decreased vasodilators, and that is why systemic endothelial damage will be there. Okay, this is the pathogenesis of preeclampsia. Everything is contained in that. Okay, so what is going to happen? Usually extravillous cytotrophoblast should be there, which will line the metal artery, so that the our spiral arteries, they increase in the diameter. But over here, because of the incomplete invasion, the arteries remain narrow and high resistance will be there. Because of high resistance, blood flow will be decreased, placental hypoperfusion will be there, and ischemia will be there. And this particular placenta, which is already ischemic right now, are going to release increased vasoconstrictors and decreased vasodilators, and because of that there is going to be systemic endothelial damage. Okay, so next one is about the severity criteria of the preeclampsia. The people who are non-severe, just remember that the BP is going to be more than 140/90, but apart from that, no constitutional symptom, no headaches, no visual symptoms and all that, no epigastric pain. But severe features are BP which is more than 160/110, severe headache, visual symptoms, scotoma will be there, epigastric pain, liver enzymes is going to be more than 2 times the normal, creatinine is more than 1.1 or doubling of the baseline will be there, heme, the platelet count is going to be less than 1 lakh. Okay, and pulmonary edema will be there. Okay, these are the few features which are there in the severe preeclampsia. At least one of them if it is present, enough. Okay, so probably oliguria, or IUGR and massive proteinuria, if at all it is there. Okay, uh, they can also be included under preeclampsia, but that is there only in few textbooks. But right now in Williams, they have been removed exactly. Okay, now next one is the multi-organ pathology in pregnancy induced hypertension. Now what you need to remember is that there is going to be leaky capillaries plus platelet activation. Because of that, systemic microvascular dysfunction is going to be there. So in the liver, what is going to be there? Vasospasm and hemorrhage. So because of that, stretching of the Glissen's capsule will be there. Okay, and presence as severe epigastric pain or right upper quadrant pain. Kidney, again vasoconstriction. That means what? Vasoconstriction means decreased GFR. That means oliguria and increased uric acid. Okay, so there is going to be glomeruloendotheliosis. In retina also there is going to be segmental vasospasm. Because of that, scotoma, Pursh's retinopathy. Okay, that's ischemia basically. Plus CNS of brain, again occipital edema will be there, plus which is going to lead to reversible cortical blindness, amaurosis. Next is about HELP syndrome. If you remember, HELP syndrome, hemolysis will be there, elevated liver enzymes and low platelet count. Okay, hemolysis. Indirect bilirubin will be increased, LDH will be increased, haptoglobin will be decreased over here. Liver enzymes, and they are 2 times more than that of the normal. Low platelet count less than 1 lakh. Okay, all these are the criteria for the HELP syndrome. So most common presentation is sudden onset of the mid epigastric pain or right upper quadrant pain in the 3rd trimester, and this is most common in multiparous females. Okay, now talking about eclampsia. So eclampsia means what? A patient having preeclampsia, along with that, if at all they come up with convulsions or coma, then we can call it to be an eclampsia. So severe hypertension, if it is there, the mean arterial pressure is going to be increased, okay, sharply. So what is going to happen? The normal cerebral autoregulation is lost in the preeclamptic patient. the increased cerebral blood flow will be there, and hyperperfusion will be there. That means what? Endothelial cell injury will be there in the cerebral vessel, leaky vessels will be there, and perivascular edema will be there. And that is the reason the patient can go into generalized tonic-clonic seizures. Okay, so when can we have it? We can have it in the antepartum, intrapartum, or the postpartum, but most commonly they get in the antepartum, which is the best prognosis, but they can get in the postpartum also. Okay, that is about 48 hours after delivery they can have seizures and all that. Next is IUGR. We have two types of IUGR. IUGR is symmetrical and asymmetrical. Okay, symmetrical is the one which we get more less than 32 weeks, and the onset of asymmetrical is usually after 32 weeks. Okay, so usually the early onset is because of the fetal cause, because fetus is not, and it's not able to grow. But later, that is after 32, it is basically because of the placental or the maternal causes. Okay. See, head is going to grow because all the blood flow is going to the head, right? But the rest of the body will remain small. It will lack nutrients and all that. That is for asymmetrical. Coming to symmetrical, the classic triggers: chromosomal abnormalities like triploidy, then trisomy 18, congenital anomalies, fetal intrauterine infections like torch and all that can be the classical triggers for symmetric IUGR. But for asymmetric, it is basically the uteroplacental insufficiency, preeclampsia or PIH, or chronic hypertension. Then again APLA syndrome, the anti-phospholipid antibody syndrome and all that. That can be the reason for asymmetrical IUGR. Okay, let us talk about the gestational trophoblastic. I think I had already mentioned this, right? The complete mole and the partial mole. But here, one thing which I think I forgot to say is that about the snowstorm appearance, I think I have mentioned. So there's a repetition. That is just ignore that. Yeah, this one we can go through. That is gestational trophoblastic neoplasia. Okay, in which we have a molar origin and we have a non-molar, or the full term, or abortion. Okay, so choriocarcinoma is there, which is the most common gestational trophoblastic neoplasia. Okay, after a non-molar pregnancy. So over here there is going to be dark red black mass. That is much important. And histopathological examination, villi are absent over here. In choriocarcinoma, villi will be absent, but in invasive mole, okay, the villi will be present, and trophoblast is going to extend into the myometrium. This invasive mole is the most common gestational trophoblastic neoplasia overall. Okay, so what are the staging? Stage 1, confined to the uterus. Stage 2, extends outside the uterus but within the pelvis. Vagina most common place. Stage 3, extends to the lung, okay, wherein we are going to get a cannonball appearance on X-ray. Plus stage 4 is a distant metastasis, liver, brain and all that. Next is about the antepartum hemorrhage. We have two types. We have placenta previa and we have abruptio placenta. So talking about placenta previa and abruptio, one thing which you have to remember is that placenta previa is painless, but abruptio placenta is painful. Okay, painful. That too why? Because of thromboplastin release. Bleeding is bright red in placenta previa, but dark red in abruptio placenta. Okay, so causeless bleeding. That is what we tell in placenta previa. On abdominal examination, uterus is relaxed, soft and non-tender. Okay, but whereas in abruptio placenta, uterus is going to be tender, tense and rigid. Okay. Fetal assessment. Fetal parts are usually easily palpable in case of a placenta previa. Heart sounds are also easily heard. Yeah, the problem is the malpresentations. It can be, first one is most common one is transverse lie and then the breech. Yeah. But in case of a abruptio placenta, that's a premature separation of the placenta. The fetal parts are not easily palpable, and neither the fetal heart sounds are heard properly. Okay, but usually what happens is in the placenta, abruptio placenta, there can be a condition where there is going to be concealed bleeding. The blood is going to enter, okay, and into the uterus, and it can lead to covular uterus, because see, blood is going to enter the myometrium, and the uterus is going to look like as if it is bruised. Okay, that is what we call covular uterus. Okay, so just a type of the placenta abruptio. Next is the placenta accreta spectrum. Remember the names accreta, increta, percreta. Okay, if at all the villi is attached superficially to the myometrium, which is the most common variety, we call it to be accreta. If at all it is infiltrated deep into the myometrium, we call it to be increta. When it penetrates the serosa, we call it to be percreta. Okay, serosa means that means what, it is outward, it is going to going outward, right? So it can infiltrate the bladder or any other pelvic structure. That is what we call to be percreta. Most common and simple one is accreta, that is superficial to the myometrium. Inside the deep myometrium, we call it to be increta, but outside the myometrium, or you can say, villi is attached to the or it penetrates the serosa, we call it to be percreta. I had already mentioned, but then just a repetition, it happens because there's an absence of Nitta-Buch layer, which is basically a fibroid degeneration of the layer. Okay, so usually it limits the trophoblastic penetration, but if it is not there, we're going to get an accreta, increta, or percreta. Okay, so when we see an antenatal USG, if we do, a large placental lacunae giving a moth-eaten appearance can be seen, thinning of retroplacental myometrium, which is less than 1 millimeter, and loss of normal hypoechoic area behind the placenta. This is what we can see in the placenta accreta spectrum. Okay, next one, coming to the maternal pelvis. So, talking about the false pelvis, it is located above the pelvic brim, and the function is basically to support the gravid uterus. Does not take part in the labor though. But when we have a true pelvis which takes part in the labor, we have an inlet, we have an cavity, and we have an outlet. Okay, inlet lies at the level of pelvic brim, and the shape is usually transversely oval. Cavity, remember, it is the one which is between the inlet and the outlet, and it is bounded posteriorly by S2 to S3 vertebra, and the shape is a truncated cylinder kind of. Outlet, okay, we split it into obstetrical outlet, okay, and then anatomical outlet and all that. Okay, anatomical outlet is basically diamond in shape at the level of ischial tuberosities. Okay, now let us talk about the pelvic inlet diameters quickly. One is the true conjugate, okay, which is basically the sacral promontory to the upper border of the pubic symphysis. Sacral promontory to the upper border of pubic symphysis, that is true conjugate, that is 11 centimeter. Then we have conjugate, that is obstetrical conjugate, okay, that is sacral promontory to the midpoint, okay, midpoint of the pubic symphysis, that is 10 to 10.5 centimeter. Okay, this is the shortest anterior posterior diameter. If less than 10, that means it is contracted pelvis. Then we have a diagonal conjugate, that is 12 centimeter. Diagonal conjugate means what? Diagonal conjugate means sacral promontory to the lower border of the symphysis pubis. Okay, the longest anterior posterior diameter this is, and the only one that can be measured clinically via vaginal examination. That is a diagonal conjugate. Okay, 12 centimeter. True conjugate 11 centimeter, obstetrical conjugate 10 to 10.5 centimeter, and diagonal conjugate is 12 centimeter. So next one is the pelvic classification. Just remember that there are 4 kinds. We have gynecoid, which is the most common one. Next one is android, then anthropoid, and the patriploid. Okay, so in which the gynecoid is the most common, which I have mentioned, in which the transversely oval, which we are going to get shape, and the transverse diameter is going to be more than the anterior posterior diameter. Okay, and this is the most common one and very good for the delivery. Okay, but we have the android one, which is a heart shaped one. android is heart shaped, okay, or you can say wedge shaped. The subpubic angle is very acute in this particular android one, and highly prominent ischial spines are there. Because of that, there's going to be deep transverse arrest your time of labor. Then we have anthropoid, in which the anterior posterior diameter is going to be less than that of the anterior posterior diameter is going to be more than that of the transverse diameter. Okay, anterior posterior diameter is going to be more than that of the transverse diameter, and the side walls are parallel and narrow. Okay, we have platypaloid, in which we have a flat ball shape, that is transverse diameter is much more than the anterior posterior diameter, and the side walls are divergent. Okay, divergent in case of platypaloid pelvis. Okay. Next one, let us talk about a little of the fetal skull and the molding grades. See, molding grades, basically the first grade is bone touches but do not overlap, which is normal one. Next one, the it overlaps but easily it can be separated. But lastly, we have a fixed overlapping, which is a sign of cephalopelvic disproportion. Okay, so this is the grades of molding grades. Okay, now coming about the sutures, we know we have coronal suture, sagittal suture, lambdoid suture. But talking about the fontanel, we have anterior fontanel and the posterior fontanel. Anterior fontanel we call it bregma, which is a diamond shaped and a rhomboid shape. But remember that the anterior posterior diameter and the transverse diameter is equal to 3 centimeter over here, and it ossifies by 18 months after the birth. Talking about the posterior fontanel, which is lambda, like a triangular shape, which is, and it is very close to that of the occiput. Okay, coming to the fetal skull, engaging diameters and all that. See, if at all we have a fully flexed one, okay, fully extended one, okay, we have the face presentation. We know, okay, face is the one presenting part. So what is the engaging diameter? That is nothing but the submentobregmatic, which is 9.5 centimeter, or we have the submento vertical diameter, which is 11.5 centimeter. So if at all the head is fully extended, we have the face, which is the presentation, and in that case the engaging diameter is going to be submentobregmatic or submentovertical. Okay, submentobregmatic is 9.5 centimeter, submentovertical is 11.5 centimeter. But if at all it is partially extended, we have the bro presentation, in which the engaging diameter is a mentovertical one, and that is the longest one, that is 14 centimeter. Okay, 14 centimeter. This is the one which always requires cesarean section. Coming to the deflexed one, that is vertical presentation, okay, in which the engaging diameter is going to be the occipitofrontal, 11.5 centimeter. We have a vertex presentation if it is flexed one, okay, normal one, which we call it to be. Then that is suboccipitobregmatic, 9.5 centimeter, smallest diameter, which is ideal for normal labor. Okay, all this and all, diameters. Let me go into, see, if we talk about denominators, okay, vertex presentation, the denominator is going to be occiput, breech presentation it is sacrum, and face presentation it is mentum. And the most common position overall, okay, is basically the left occiputor transverse. Okay, and then the second most common is the left occiputor anterior one. Okay, most common malposition, if we talk about it, is occiputor posterior. So these are the few pointers which you have to remember. Apart from that, if you remember the Leopold maneuvers, that is funnel grip. So funnel grip says what? It gives an idea of the lie and the presentation, right? So if it is a hard globular, it is a head, and if it is a broad and soft, it is going to be the buttocks. Coming to the lateral or umbilical grip, in which we get to know the position of the fetus. Right? Broad, board-like or a smooth one says the back, and knob-like structures tells you the limbs. Coming to the pollex grip, they're going to tell you whether there is a mobility, ballotment, engagement is occurred or not. And deep pelvic grip is going to just confirm the pollex grip, okay, engagement and attitude. Next one, if at all we do a symphyseal fundal height, we check for a symphyseal fundal height, because see, we say that symphyseal fundal height is equal to the weeks of gestation, right? So what are the things in which the uterus is less than that of the period of gestation, if at all we get a wrong date? Multifetal pregnancy, polyhydramnios, molar pregnancy, macrosomia, or any kind of abruptio placenta and all that, and even a full bladder. When uterus placenta is less than half a period of gestation, again wrong dates, IUGR, IUD, oligohydramnios, premature rupture of membrane, and even transverse lie. Because see, transverse lie reduces the vertical fundal height, right? Because transverse lie is something like this. Baby is lying like that, it's stretching sidewise, not in the you know vertical. Next one, a little about placental architecture. So placenta at term is 500-gram weight, and its diameter is 15 to 20 centimeter with a thickness of 2.5 centimeter. Quite important. Weight of the placenta at term is 500-gram. Diameter is around 15 to 20 centimeter, and thickness is around 2.5 centimeter. Okay. So now tell me, fetal site and placental sites are there. Okay. The origin of fetal site is basically chorionic frontosome and cytotrophoblast, whereas the maternal one is decidua basalis. We had already mentioned it, right? And now what you need to remember is that which is the one which is more, whether the maternal side is more or the fetal side is more. Always remember the composition of the placenta. The fetal side forms 4/5 of the placenta, whereas maternal side is 1/5 of it. Okay, fetal side, as you can see, they are shiny, they are gray in color because the amniotic membrane is attached to it, right? But whereas the mother side is full of blood, cotyledons, lobules and all will be there, so they are rough, dull red maroon color and all that, because functional unit is there at the maternal side. Okay, so the circulation is basically fetus placental circulation, okay, which has been established by day 17 and having a blood volume of 350 ml. But when we talk about the maternal side, that is by uteroplacental, established by day 15, and 150 ml of blood will be there in the intervillous phase from the mother. Okay, and next one, placental membrane barrier, okay, in which we have syncytial trophoblast. Remember, they lack intracellular junctions. Okay, that's a major barrier. We have cytotrophoblast, which is otherwise one of the Langhans cells of cell layer. Then extra embryonic mesoderm and fetal capillary endoderm. So these are the ones which separates the maternal and the fetal blood. Okay, from outside to inside. Remember, syncytial trophoblast, cytotrophoblast, extra embryonic mesoderm, and fetal capillary. Okay, but there is one particular, there are few viruses like treponema pallidum, then listeria, then toxoplasma. These are the one which can breach the barrier. Okay, next one, a little about the endocrinology. Sorry. Next is about so that is about HCG. I think I've already mentioned about HCG, the functions of it. But remember, it has been the source of HCG is basically syncytial trophoblast. May it be the HPL, may it be the HCG. They both are from syncytial trophoblast. HCG, the peak of it is 10 weeks, whereas HPL it is from 34 to 36 weeks. Okay, so function I have already mentioned, but what you need to remember is that in HCG we have two. We have alpha and we have beta. Beta subunit is the one which is very much specific for pregnancy. The doubling, and it doubles every 48 hours initially. Okay, talking about HPL, remember it is for maternal insulin resistance leading to GDM. Okay, coming to estrogen, estrogen it's converted from fetal adrenal dihydroxyepiandrosterone sulfate, right? And it requires placental sulfatase or aromatase. Peak time is at term. Okay, and what's the function? It initiates uterine contraction. So which is the estrogen which is most important in pregnancy? Remember, estriol. Okay, estriol is important. Then progesterone talking about it, maternal HDL cholesterol. Okay, that is the source from where progesterone is going to come. Okay, till 8 weeks we know that is our corpus luteum. Next, what's the primary function? It smooth muscle relaxant, prevents fetal expulsion and all that. Okay, and functional withdrawal of the progesterone is going to lead to labor. That is much important. Next is type of placental separation. We have two kind of placental separation. One is a peripheral one and the other one is central one. Peripheral one is known as a Duncan method. Central one is known as a Schulz method. Okay, shiny Schulz. Remember, S for S. Shiny Schulz. So shiny fetal side comes out first. Okay, the shiny fetal side which is going to come out first, that is called as a central method. Okay, so start separating from the center. So there is going to be retroplacental clot formation is going to be there. Okay, bleeding is going to, we can see the bleeding only after separation is completed, and this is the most common one. Whereas Duncan method or the peripheral one, what happens is over here the maternal side is going to come out first. Dull maternal side is going to come out first. So when the maternal side is going to come out first, definitely bleeding is also going to come, right? So evident as soon as bleeding is evident as soon as the separation begins. Okay, heavier bleeding will be there. There is no clot, retroplasmal clot and all is not going to be there. So compared to the Schulz method, Duncan method is less common. So dull Duncan and shiny Schulz. Remember, central and peripheral. Okay. Now there are a few other placental morphologies also, anomalies basically. See, there can be placentomegaly, right? Thickness of the placenta, if at all, it is more than 4 centimeter. So we had already mentioned that. How much is the thickness of the placenta? That is 2.5 centimeter. But if at all it is more than 4 centimeter, we call it to be a placentomegaly. So what are the causes? It can be because of fetal high cardiac output or maternal diabetes or syphilis. Okay. Now, apart from that, we can have lobar defects. Okay, lobes, nearly 15 to 20 lobes are present in placenta, right? But if at all a placenta succinata, if at all it is there, that means that some small accessory lobe is separate from the main lobe. I'll just show you. That means what? See, this is a particular lobe and one more lobe is present. A small accessory lobe will be present and it is separate from the main placenta and it is connected by vessels. That is what we call it to be placenta succinturiata. Okay, so this is having a risk of vasa previa. After that, we call it to be placenta bilobata. So two equal lobes of placenta will be there. Lobes are going to be there, and it is separated by cords. Okay, the risk factors are PPH and infections can be there. But apart from that, extracorporeal anomalies like circumvallate placenta. Basal plate is bigger and the fetal membranes form a valve or valve like a fold ring. Okay, and vessels do not extend beyond the chorionic plate, because of which there can be abruptio placenta, there can be preterm labor, there can be fetal growth restriction and all that. Next one is about the umbilical cord. See, talking about umbilical cord, we know we have vessels, two kind of vessels are there, right? Two arteries are going to be there and one vein is going to be there. So two arteries, they are going to carry deoxygenated blood to the placenta. One vein is going to carry 80% of the oxygenated blood to the fetus. Okay, so what is going to happen to the arteries? Umbilical artery. Okay, they are going to form medial umbilical ligament and vein is going to form ligamentum teres. And the normal length of the umbilical cord is around 40 to 70 centimeter. Okay, 40 to 70 centimeter. So let us see. How are we going to find out if there is a problem or not? See, if at all there is a single umbilical artery, okay, single umbilical artery, we're going to do a ultrasound, Doppler USG. Okay, perform an anomaly scan. If at all it is a normal fetus, okay, there is going to be isolated single umbilical artery. No risk of aneuploidy, so no need of a karyotyping. But if at all along with a single umbilical artery, there is going to be other anomalies also like genitourinary or CVS, then there can be a risk of aneuploidy like aneuploidy 18 or 21. Okay, then in that case we are supposed to confirm which is the trisomy, right? So we have supposed to go for a karyotyping. Okay, so what is the most common vascular anomaly? That is left umbilical vein plus single allantoic artery. This is the one which you have to remember. Most common anomaly, vascular anomaly is left umbilical artery and single allantoic artery. Okay, next one, talking about cord incision. Normal cord incision is where central part, okay, it is attached securely to the fetal side of the placenta and it is protected by the Wharton's jelly. But sometimes what happens, the cord is attached to the margin. Cord, it is attached within 2 centimeter of the placental edge. Okay, that is what we call to be battledore. Okay, battledore. Cord avulsion can be there during the third stage of traction, and because of that there can be always a chance of PPH or a retained placenta. Next is a filamentous placenta. Cord ends. See, cord ends before attaching to the placenta. Okay, cord ends over here only. After that, the vessels are just without any Wharton's jelly and all that. Okay, so diverse blood vessels can be seen without Wharton's jelly across the amnion or chorion to attach. So what happens? there is always a chance of compression, right? Fetal distress can be there, and there is most common cause of vasa previa. Okay. So now little difference between vasa previa and placenta previa diagnosis. See, for that we are not supposed to find out whether the blood is of the maternal blood or the fetal blood, correct? And we have already a test which we have already discussed, that is Aiapget test, okay, or Singer's alkali denaturation test, okay, in which vaginal blood sample is being taken and we add 1% of NaOH, okay, sodium hydroxide or the potassium hydroxide uh, reagent, okay. If at all, the biochemical principle is what? Fetal hemoglobin is resistant to acid and alkali, correct, but adult one is sensitive. So if at all the color changes, that means it is sensitive, that means it is adult hemoglobin. That means what? The blood is of the mother, it can be a placenta previa. But if at all no color change, that means it is fetal hemoglobin, that means diagnosis is vasa previa. So which is a test? Aiapget test, otherwise we call it to be Singer's alkali denaturation test, okay, denaturation test, remember. Apart from that, let us see about the cord prolapse. See, talking about cord prolapse, remember we have overt cord prolapse and occult cord prolapse, okay. See, the after the membrane gets ruptured, the cord usually slips along the fetus, right? So now the cord, what is happening? The cord is exposed to the external environment, so there is no vasoconstriction or cord compression, and thus leading to fetal hypoxia or distress. Okay, now suppose the cord slips ahead of the presenting part and prolapses into the cervix or vagina, we call it to be overt cord prolapse. But if at all cord slips alongside but not ahead of the presenting part, okay, along with the presenting part only it is there, then there can be cord compression. Okay, so what are other features where cord prolapse can be there? Transverse lie, footling breach, and vertex. Vertex is the least common one. This polyhydramnios also can lead to unengaged presenting part at the time of membrane rupture. That also can lead to a cord prolapse. Next is amniotic fluid, a little bit of it. See, talking about it, let us talk about 12th week of pregnancy. In 12th week of pregnancy, the amniotic fluid volume will be approximately 50 ml. Okay, because that is the time when fetal urine production begins and all that, right? So 50 ml. 20th week it becomes 400 ml. Okay, 400 ml. Because there are fetal skin keratinization also occurs and the transudation from the skin and all will occur along with the fetal urine. By 34th week, it is peak, that is 1000 ml, maximum capacity. By 40th week, it is going to decrease to 800 ml. Okay, and if it is a postpartum more than 42, drastically it is going to decrease to 200 ml. Okay, and that time it becomes oligohydramnios, risk will be there. So when we talk about urine production, remember fetal urine 650 to 1000 ml per day will be there. Okay, plus fetal lungs. Okay, it swallows nearly around 350 ml per day. Clearance, that is fetal swallowing, that is 750 ml per day, and intramembranous flow. These are the ones which you have to remember. But apart from that, we have a color change. See, if at all the color of the amniotic fluid is clear or straw, that is normal. Green, that means meconium, due to fetal distress, transverse lie or breach or listeria infection. Golden, that means bilirubin is there, RH incompatibility. Tobacco juice or brown color, intrauterine fetal death. Saffron or green color, postterm pregnancy. Dark red, it means there is a concealed hemorrhage, can be because of abruptio placenta. Okay, now how are we going to measure the amniotic fluid? By measuring the by calculating the amniotic fluid index. Now how are we going to calculate? We are going to calculate the largest vertical pockets in the 4 quadrants of the placenta. Normal is 5 to 24 centimeter. One more method is by calculating the single deepest pocket, okay, which is the most sensitive one, that is 2 to 8. So if at all there is a oligohydramnios, the amniotic fluid index should be less than 5, or the single deepest pocket should be less than 2 centimeter. If it are polyhydramnios, the greater value we take. Amniotic fluid index should be more than 24, and single deep pocket should be more than 8 centimeter. So more than 24 or 25, and more than 8 centimeter is going to give you polyhydramnios, but less than 5 centimeter and less than 2 centimeter is going to give you oligohydramnios. Okay, so now a little bit of oligo and poly. So polyhydramnios, what happens? There are two mechanisms. Either there is an increased urine production or decreased swallowing. Okay, excessive urine production, in which case maternal diabetes, correct, and high fetal cardiac output there can be. Okay, that means high fetal cardiac output, what is going to happen? There is going to be increased GFR and then polyuria. But whereas in decreased swallowing, what is going to happen? Probably there's a problem with the GI or the dural atresia or tracheoesophageal fistula or neural tube defects and all that. Talking about oligohydramnios, which is more than AFI, more than 5 centimeter, here they can be decreased, just opposite of it. Decreased urine production, probably because of problem with the kidneys, bilateral renal agenesis or polycystic kidneys, or posterior urethral valves. Okay, then it can be because of uteroplacental insufficiency, wherein there is a PIH or hypertension leading to decreased fetal blood flow. Then all the blood is going to go to the brain, right, and decreased renal perfusion is going to be there, and because of that oliguria. Okay, so these are the few things in the pathophysiology of the polyhydramnios and the oligohydramnios. Next one, this one everyone knows actually, but still I'll just go through. That is Naegele's formula, right? And how is the Naegele's formula different in IVF modifications? So we know first day of the last menstrual period plus 7 days plus 9 months. That is what how do we calculate? Okay, calculate in a regular 28-day cycle. Okay, but if it is a shorter cycle, that is less than 28 days, how are we going to calculate? Calculate it by subtracting 28 days, okay, from the cycle length. 28 minus cycle length in days is going to give you the answer. Longer cycle length minus 28, okay, in days. Coming to IVF conceptions, remember ADD means day of oocyte retrieval plus 266 days. But if it is a frozen embryo, the day it gets transferred plus 263 days. For a day 3 transfer, it should be 261 days. Okay. Day 3 263, day 5 261 days. Next one, a little about investigations. See, we go in for ultrasonography, right? See, diagnostic rules, what are the things? When we go for a TVS or a TAS, they find out a fetal biometry, they do Doppler studies, they do cervical length assessment, amniotic fluid volume, detailed fetal anomaly scans and all they do. So what are the normal things? See, appropriate gestational age, amniotic fluid index, biophysical profile, umbilical artery Doppler, or fetal growth, normal umbilical growth, normal amniotic fluid, all these stuff are supposed to be normal. But if at all have some kind of hypertensive disorders, okay, so what is going to occur? We are going to quickly the gold standard is basically the uterine artery Doppler notch, fetal growth restriction, as well as oligohydramnios should be present. Whereas in case of fetal growth anomaly, fetal growth restrictions, abnormal umbilical artery Doppler, brain sparing defect, and decreased abdominal circumference will be there. If a baby is having macrosomia, going to have polyhydramnios, increased abdominal circumference, and large for gestational age. Okay, coming to multiple gestations, in which we can see twin transfusion syndrome, selective fetal growth restriction, and twin anemia polycythemia sequence. This and all will be there in case of our ultrasonography findings. Now coming to IUGR, okay, we have symmetrical IUGR, we have asymmetrical IUGR. Symmetrical is the one which is early onset, which is less than 24 weeks, but asymmetrical is late onset, that is more than 32 weeks. Okay, in which this asymmetrical is because of the uteroplacental insufficiency. The other one is intrinsic one. Okay, probably chromosomal defect or torch infections and all that, symmetrical. But whereas our asymmetrical is uteroplacental insufficiency, and there is head circumference is preserved, but abdominal circumference is decreased over here. And in case of symmetrical, all organs are proportionally affected. but asymmetrical no. Brain sparing effect, right? So other particular parts of the body will be less in the size than that of the head. So diagnostic marker for IUGR, going for a head circumference for abdominal circumference ratio, which is normal. Okay, ponderal index is also going to be normal, but we require a karyotyping, okay, and a level 2 targeted scan. But whereas the asymmetrical one, head circumference is going to be more than that of a abdominal circumference. Ponderal index is also going to be there, which is going to be less than 10 percentile. Okay, it reflects a fetal nutrition. So in case of fetal hypoxia, what are the 2-3 things which you're going to see? First sign, go for an umbilical artery. Okay, check for umbilical artery. Absent end diastolic flow will be there, and then a reversed end diastolic flow. Then check for the middle cerebral artery compensation method. Okay, brain sparing effect will be there. That there is a resistance in the middle cerebral artery that is going to be decreased. Then ductus venosus. The last vessel to show reversal of end diastolic flow is the ductal venosus. Okay, this is going to indicate the impending fetal death. Next is about the multiple pregnancy. Just remember that from day 0 to 4, okay, if at all the fusion, okay, occurs, okay, the multiple pregnancy, okay, it occurs, we are going to get a dichorionic diamniotic. Okay, dichorionic, still that fusion has not occurred, right? In day 0 to day 4. So membranes are formed independently. But 4 to 8, okay, already there's a fusion. So we are going to get a monochorionic but diamniotic, 2 amniotic. This is the most common monozygotic type. Day 8 to 12, everything is merged. We will get a monochorionic, monoamniotic. Okay, there's a high risk will be there for the cord entanglement over here. Then more than day 12, we are going to get conjoined twins, so Siamese twins. Okay, the most common one is paraphagus, where the lower abdomen of the pelvis is fused together. Then apart from that, we have thoracopagus, tachypagus, and all that. Okay. So how are we going to find out? We are going to find out through ultrasonographic markers. In the first trimester, in case of a dichorionic diamniotic, we are going to get a lambda sign. Okay, lambda sign. Here you can see thickening, right? A twin peak sign. The placenta extends between the chorionic layers. There's a thickness is going to be more than 2 millimeter, because there are going to be 4 layers over here. 2 placentas may appear fused. That is why lambda sign or the twin peak sign. But whereas a monochorionic, monoamniotic or diamniotic, there is going to be a thin line over here. So T sign will be there. T sign. Okay. So and the thickness will be less than 2 millimeter, or sometimes absent in case of monoamniotic one. And there will be a single shared placenta. Here 2, but it looks like fused. Here only 1. Okay, T-shaped. So when are we going to find out the chorionicity? Best one is by 10th week. Okay, by 10th week it is best to know the chorionicity. So what are the complications that can come in multiple pregnancy? Remember, monochorionic, we are going to have a twin transfusion syndrome. Okay, there is going to be deep vascular anastomosis, artery vein, and unidirectional volume flow also will be there from donor to recipient. So what happens in donor? Donor is going to have a hypovolemia, RAS activation, oliguria, oligohydramnios, and finally RAS activation, there is going to be anemia. Okay, oligohydramnios in case of a donor one, but the one which is going to get it, they're going to hypervolemia, polyuria, polyhydramnios is going to be there, and polycythemia will be there, and ultimately congestive heart failure will be there in case of a recipient one. The donor is going to go into anemia, and all the blood, when it reaches the recipient, they're going to get a polycythemia. Okay, apart from that, we have twin anemia polycythemia sequence. Okay, slow transfusion of RBCs are going to occur through very small superficial artery vein anastomosis. Okay, apart from that, TRAP, okay, twin reversed arterial perfusion will be there, in which one twin will not have a heart, acardia will be there, other one is going to have a normal heart. So the pump twins umbilical artery sends deoxygenated blood back to the umbilical artery of the recipient twin. That is what happens in the TRAP syndrome. Okay. And again, selective FGR. Okay, over here normal twin and FGR. Over here what exactly happens is the fetal weight will be nearly less than 10th percentile, and the weight difference also will be there between these twins. Okay, unequal placental sharing, unequal splitting of the initial cell mass. Okay, that is what happens in the selective IUGR. Next one, a little about RH incompatibility. See, we know that RH negative mother, RH positive mother. So automatically, if at all we have an RH positive fetus, and by chance any trauma, bleeding, or during the time of delivery, the fetal blood is going to enter the RBCs. Okay, the fetal blood is going to enter the maternal circulation. So initially, what is going to happen? The mother's immune response is going to act up, and it's going to produce IgM antibodies. Okay, that's it. But after that, if the second time if the lady becomes pregnant and the same thing occurs, re-exposure is going to cause a rapid production of IgG antibody, and that is going to cross the placenta and target the fetal RBCs and leading to severe hemolysis. Okay, this is what happens in RH incompatibility. How are we going to test it? Maternal screening for hemorrhage we are going to do. Rosette test is going to do. Okay, if at all fetal-maternal hemorrhage is present, it will be positive. Clear Bedke test I have already mentioned, done within 2 hours of delivery. It is going to calculate exact amount of the fetal blood which is there in the maternal blood, and then pump it out. Okay, and then give that much amount of anti-D into the mother. Then fetal surveillance for anemia we can do. That is Doppler of middle cerebral artery. Okay. Next is about hydrops fetalis. See, in hydrops fetalis is the diagnostic criteria there is, and see that is pericardial effusion will be there. There is going to be ascites, pleural effusion, and subcutaneous edema. These are the 4 things which is going to be there in hydrops fetalis: pericardial effusion, ascites, pleural effusion, and subcutaneous edema. Okay, subcutaneous edema is going to look like a Buddha sign. Next one, immune and non-immune. In case of an immune, it is exclusively for RH negative one. Okay, RH negative. But whereas non-immune is more common, and it is for CVS abnormalities and all that. In case of immune, it occurs when fetal hemoglobin is less than 5 gram percentage, but non-immune for chromosome anomalies. Okay. Next is preterm labor, in which there is going to be 4 things which you have to remember. Number 1, there is going to be fetal or maternal stress. See, probably IUGR or any chronic disease or uteroplacental insufficiency. What is going to happen? Increased placental corticotropic hormone is going to be released. Fetal HPA axis is going to get prematurely activated. Cortisol is going to come out, and fear progesterone withdrawal will be there. So whenever progesterone withdrawal is there, that means what? There is going to be labor is going to start, right? Okay, next one, infection. Any kind of infection is going to asymptomatic bacteria or bacterial vaginosis, anything can lead to endotoxin production. Phospholipase A2 production going to lead to inflammatory markers like interleukin 1, tumor necrosis factor alpha and all that, and leading to prostaglandin again is going to lead to labor. Then residual hemorrhage, release of thrombin. Thrombin will release metalloproteinesis, and that is going to help in membrane degradation and progesterone withdrawal. Again, labor cascade. Then uterine overdistension is going to increase the gap junction and oxytocin receptors. Again, it will release prostaglandin, and that is going to lead to uterine contraction. Okay, that is how the preterm labor works. But how are we going to predict it? We are going to check for the cervical length in the transvaginal sonography. If at all the transvaginal sonography, the cervical length is less than 2.5 centimeter, we can predict that this particular patient is going to have a preterm labor, high risk. If at all it is less than 2 centimeter or less than 20 millimeter, it is definitive for preterm labor. Coming to biochemical marker, what are we going to do is we are going to take the cervicovaginal swab, okay, in which fetal fibronectin, okay, if at all that is more than 50 nanogram per ml, it is positive. That means this person is going to have a preterm labor. What exactly happens is the extracellular matrix protein, okay, at the chorionic deciduous interface, when the contraction happens or rupture happens, they disrupt and they get into the vaginal secretion. And that is how we get to know that, okay, this particular lady is going to go into a preterm labor. So fetal fibronectin protein, remember, cervical length, please remember that. Okay, next is about the little bit of pph. uh, yeah, pph. So primary pph we have. Okay, and along with that we'll little learn about the uterine inversions also. See, talking about pph, within 24 hours there should be primary pph. Excessive bleeding will be there, and most common cause is atonic uterus. The tone of the uterus is absent and flabby, and vaginal bleeding will be there. But when we talk about uterine inversion as such, it is acute within 24 hours. Should be there. Shock will be there out of proportion to the bleeding. Cup-like depression will be there below the umbilicus, and a rounded mass filling the vagina with the bleeding will be there. Okay, one more is that amniotic fluid embolism. See, at the time of labor or within 30 minutes of the labor, it should occur. There should be cardiorespiratory arrest, breathlessness, and cyanosis. Abdominal finding and the vaginal findings are going to be normal in this particular case. So uterine inversion, what is going to happen? First degree is fundus dimpling. Okay, it does not reach the os. Second one, fundus is at the os, near the introitus. So inside the introitus. And finally, fundus will protrude out through the os. And later, entire fundus is outside the introitus. That is fourth degree. Okay. Next is about malpresentation. Let us talk about it, and that is occipito-posterior position. Okay, we have complete forward one, incomplete forward rotation, and posterior rotation. Now, what you need to know is, whenever there is a complete forward one, there is going to be normal delivery. Incomplete forward rotation, there is going to be deep transverse arrest at the level of ischial spine. Okay, this is most common in android pelvis. And posterior rotation, there is going to be persistent, occipito-posterior, it delivers face to pubis. And the occipito-posterior outcome is basically, the engaging diameter is basically the occipito-frontal one, that is 11.5 centimeter. Coming to the transverse lie, face and the brow. See, in case of transverse, denominator is acromion process. Highest risk is cord prolapse. Okay, prematurity, placenta previa, all these are the most common cause of and because of transverse lie, these are the causes which can come. Face presentation, denominator is mentum. Delivery is through flexion, and the diameter, engaging diameter is submentum bregmatic, 9.5 centimeter. Brow presentation, frontal bones are the denominator. Mentovertical, that is 14 centimeter is the engaging diameter, and there is no much mechanism of labor over here. Okay. Breech. Types of breech, we have frank breech, most common, complete breech, and fluteling breech. Okay, so breech, what is the denominator? It is the sacrum, and engaging diameter is basically bitrochanteric diameter, that is 10 centimeter. Okay, the lowest chance of cord prolapse is the breech one. Okay, hips are flexed, knees are extended. Complete breech, hips and knees are both are flexed. Okay, footling, hips are extended, knees are extended, both are extended. So maximum chance of cord prolapse is in footling breech. So let us see about instrumental delivery prerequisites. Cervix is fully dilated, head is engaged, ruptured membranes such as suture in AP diameter, and bladder empty, and uterus is contracting. The absolute contraindications are CPD, that is cephalopelvic disproportion, inadequate pelvis, known fetal bony deformities, fetal coagulopathy, and if at all the mother is HIV positive. So, what are the complications which can come? Vacuum delivery. Okay, higher fetal injury can be there in vacuum delivery. There can be a sixth nerve palsy, shoulder dystocia, cephalhematoma, subgaleal hemorrhages, and retinal injury. Whereas in forceps delivery, high metal injuries most, like tears and all that, perineal tear. Apart from that, facial nerve injury for the fetus, brachial plexus injury for the fetus, and corneal injury for the fetus. Okay, higher metal injury is usually in the forceps delivery. Next, coming to the cesarean, we have a classical cesarean and we have a lower segment cesarean section. Which is more problematic? Classical cesarean section. Okay, the less bleeding, better healing is lower segment cesarean section. That's it. Puparium time, we remember we have something called uterine involution. See, immediately, okay, after the delivery, uterus is around 100,000 gram, 1 kilogram, okay, and the level will be at the level of umbilicus. After 1 week, it will be midway between the umbilicus and the symphysis pubis, and the weight is going to be around 500 gram. By 2 weeks, it is not palpable abdominally. It has become a pelvic organ. That is 300 gram. And by 4 weeks, involution is complete. Okay. Coming to lochia, we have lochia rubra, lochia serosa, and lochia alba. Okay. Lochia rubra, lochia serosa, that is more than 4 to 9 days. Then we have 10 to 15 days around, that is lochia alba. But right now, if at all you see the Williams, there is an average that is 24 to 36 days it can go. That is lochia. Okay. Then blood volume, it normalizes by first week. Cardiac output, it is elevated for 10 days to 48 hours. And GFR, it normalizes in 2 weeks. Menstruation returns by 6 to 8 weeks, if at all partially or not the complete breastfeeding which has been done. Weight loss 5 to 6 kilo immediately, and subsequently 2 to 3 kilo will be there due to postpartum diuresis and all that. So what are the complications? They can be subinvolution, okay, incomplete remodeling of the spiral arteries, or refragmented, so retained parts of placenta and all that. So there is going to be thick endometrium with vascularity and hypoechoic areas in USG finding. Coming to pubertal pyrexia, that is more than 38 degrees Celsius or 100.4 degree Fahrenheit on 2 days, that too within first 10 days. Okay, so this is the most important risk factor, and that is cesarean section. Apart from that, obstetrical neuropathies can occur, that is lateral cutaneous nerve of the thigh, which is the most common vaginal. Okay, there is going to be burning and numbness in the upper outer thigh. Femoral nerve can be included or involved, in which we are going to have quadriceps weakness. Peroneal nerve can be there, in which the food drop can be there because of prolonged squatting and all that. So this was about it. Next is about the little bit of attitude. So well flexed, okay, well flexed was a normal one, well flexed head. Remember, the what you can say, the attitude. Okay, attitude is, you can see that everything is flexed towards each other. It is palpated at a higher level. Okay, the head is palpated at a higher level. And remember, both the prominences, may it be the occipital prominence, everything can be felt on opposite sides. Finger will converge below the head in the leopard fold maneuver. But whereas when in a case of extended head, okay, the legs are palpated at a higher level, very felt easily, and the occiput is palpated at a lower level, because both the prominences which are there, they are felt on the same side actually in case of our extended head. Okay, next a little bit of asynclitism. See, engagement, we know engagement occurs when the largest transverse diameter, it passes through the pelvic inlet, correct, that is station 0 or the below. Synclitic means what? The sagittal suture equidistant between pubic symphysis and the sacral promontory. So what is anterior asynclitism? Okay, now over here, the anterior parietal bone is felt first on pervaginal examination. We call it to be Naegele's obliquity. Sagittal suture is deflected towards the sacral promontory anteriorly. Okay, and it is most common in multiparous females, whereas posterior one, it is most common in nulliparous female, and it is known as Litzman obliquity. Posterior parietal bone is felt first, not the anterior one. Then sagittal suture is deflected towards the pubic symphysis in case of a posterior asynclitism. Apart from that, you can see there is a Bishop score, modified one. This is in which the maximum score is 13. Length of the cervix, if at all it is more than 4 cm, we have 0, 2 to 4 1, 1 to 2 2, and less than 1 3. Dilatation closed 1 to 2 cm, 3 to 4 cm, more than 5 cm. Position posterior, mid, and anterior. Consistency, so basically we are going to search the length of the cervix, dilatation, position, consistency, and station, okay, at which it is there, and then count it up. If it is maximum score is 13, that is quite a good one. So labor, a little bit of endocrinology of labor initiation. See, we know fetal hypothalamus is there, right? Fetal hypothalamus is going to release fetal corticotropic hormone. Okay, that is the primary initiator. Now that is going to lead to uh, the the pituitary gland of the fetus is going to release fetal ACTH. So what we have, it is going to act on the fetal adrenals. So fetal adrenal is going to produce fetal dihydroxy epiandrosterone sulfate. Okay, that is going to convert. Okay, that is going to go into the placenta. The placenta converts it to the estrogen, that is E3. Correct. So that one plus the fetal adrenals are going to produce cortisol, and placenta is going to release placental corticotropic hormone. So now what is going to occur? We have placental corticotropic hormone and we have estrogen. Okay, so together they are going to release prostaglandin, increase oxytocin receptor, and increase myometrial gap junction. Ultimately increase intracellular calcium, which is going to cause contraction, and thus the labor is going to start. Okay, next one, a little about uterine contractions again. The origin of uterine contraction, where is it? It is basically at the cornua, that is the angle of the uterus. First is right, then the left. Okay, how is it spread? 2 centimeter per second, that is how it spreads. And upper segment contracts, and then at the same time lower segment relaxes. So difference between true labor pain and a false labor pain: regular and rhythmic is true, increase in the intensity and frequency will be there, progressive dilatation of the cervix, lower abdominal pain with radiating to the back and thigh will be there in the true labor pain. Blood and mucus show will be present basically, and not relieved by any kind of medications or enema. But whereas false labor pain, there is going to be irregular and continuous, no progression, no cervical dilatation, it is localized only to the abdomen, show will not be there, and it is not relieved by any kind of sedation or enema. Okay, it is relieved by sedation and edema. So coming to the stages, first stage, onset of true labor pain will be there and it ends in the full dilatation of cervix, that is 10 centimeter. So here cervical effacement and will be there and progressive dilatation. Second stage, there is going to be full dilatation of the cervix and delivery of the fetus. Okay, and cardinal movements and expulsion is the one which is going to occur. In third stage, then after delivery of the baby, there is going to be delivery of the placenta over here. Placental separation will be present in this particular stage. Fourth stage is 1 to 2 hour observation stage. Okay, wherein physiological vitals or uterine tone or the postpartum hemorrhage, all those are being checked in the lady who has just delivered. So what are the mechanism of labor? First is engagement. Okay, largest transverse diameter, that is a biparietal diameter, passes through the pelvic brim. Okay, next is descent, continuous descent. Then at the when the baby's head, when the fetus head touches the pelvic floor, there is going to be flexion. Okay, after flexion there is going to be internal rotation, flexion, and then 2/8 the head is going to rotate. Okay, occiput rotates anteriorly, after which we are going to get an extension. Okay, extension, the delivery of the head is going to occur, basically crowning, and then the extension, occiput, vertex, brow, and the face is going to come out, and then restitution, head is going to untwist posteriorly 1/8 of it. Okay, and finally we have the expulsion. Partogram, not that important, just remember that there is going to be a cervical dilatation and by time. Okay, usually 1 centimeter per hour, that is how the cervical dilatation is supposed to occur. Okay, but if at all it is going to be less than 1 centimeter per hour, we call it to be a protracted active phase, and if at all it is more than 6 centimeter dilatation per hour, it is known as an active phase arrest. Okay, so let's see a little about obstructed labor. See, basically we have something called a Bandel's ring, which is a pathological one, and constriction and Schroeder's ring. Okay, so pathological retraction ring is the one which we call it to be a Bandel's ring. It is a consequence of obstructed labor. Okay, so basically what happens is that there is an obstruction which is formed, a band which is formed between the thickened upper uterine segment and the thin lower uterine segment. Okay, so probably it should be something like this. Okay, there will be a complete demarcation over here. A constriction will be found, so can be seen and felt per abdomen. So fetal parts are not easily felt easily, and signs of fetal distress will be present in case of Bandl's ring. But whereas constriction ring or Schroeder's ring, there is basically localized spasm of uterine muscle. Okay, so probably because of use of uterotonics and all that, and can occur anywhere. So what happens is we can actually feel per vagina, okay, and never seen or felt it per abdomen, and fetal parts are felt normally over here. And lastly, let us see about a postpartum hemorrhage. See, postpartum hemorrhage means what? The blood loss which is more than 500 ml after vaginal delivery, and blood loss more than 1000 ml after cesarean section. Okay, so severe postpartum means more than 1000 ml. Correct. So now we have two types. One is primary postpartum hemorrhage and secondary postpartum hemorrhage. Primary is the one which occurs within 24 hours of the delivery, and the most common cause is atonic uterus. Then the trauma and all that. Other causes are trauma, coagulopathy, all this. But later we have something called a retained postpartum hemorrhage. The bleeding which occurs after 24 hours, and it is still 12 weeks they can be bleeding post delivery. And the most common cause is retained placental tissue. Okay, so here for postpartum hemorrhage, remember about 4 T's: tone, trauma, tissue, and thrombin. Okay, tone, trauma, tissue, and thrombin. So these are the things which you have to remember about postpartum hemorrhage. So with this I complete a little about the important topics in obstetrics. Hope you'll be going back, reading it again and again, and then going for the exams. Wish you all the best. Do practice the MCQs so that you'll be a master in solving it later. Thank you.